Hi, my name is Dana Martin, and I'm a member of the events team here at Worldwide Clinical Trials. Today, I'm excited to present you with our latest on-demand webinar presented by Tomislav Davic, our Vice President of Neuroscience. Please enjoy.
Hello, good day. My name is Tom Davic, and I'm very pleased to be with you today. And I would like to thank the organizer giving me the opportunity to talk about overcoming challenges of drug development in behavioral variants of frontotemporal dementia. All of the authors are employees of Worldwide Clinical Trials, which is the global CRO responsible for drug development, particularly in neurodegenerative disorders. At the beginning, a few words about frontotemporal degeneration, which is in fact pathologically heterogeneous neurodegenerative disorders with a various rate of disease progression and includes several conditions known as behavioral variant of frontotemporal dementia, corticobasal syndrome, primary progressive aphasia, and progressive supranuclear palsy. Although considered rare, frontotemporal degeneration represents the second most common type of early onset dementia, predominantly affecting younger population than Alzheimer's disease, and therefore it's thought to have an even greater deleterious effect on the lives of patients and their families. It is typically diagnosed in a middle age with average age of about 56. And although it has been reported in patients in earliest 30s, with practically 13% of patients with the onset below age of 50. There are several different reports about incidence and prevalence of the frontotemporal degeneration. The Rochester study basically showed that the incidence is about 4 per 100,000 people, whereas prevalence is varies between 15 and 22 in various countries, including UK, Netherlands, and United States. We know today that 15 to 20% of patients have a familiar presentation, and it should be difficult to be diagnosed, particularly in early stage of disease, where the average delay of diagnosis is about 3-6 years, whereas 2.7 is in Alzheimer's disease. The mean survival time in all FTD patients is roughly about 10 years. Here, there is a schematic review of a behavioral variant of frontotemporal degeneration as one of the most common type of frontotemporal degeneration. And there are also other conditions which are belonging to the group of frontotemporal dementia. So frontotemporal dementia is in fact a conglomerate of the various phenotypes, which are including behavior disorders, cognitive disorder, language and movement disorder. Frontotemporal dementia of behavioral type is probably the most common type of the frontotemporal dementia, and it is in fact present in more than 50% of all patients. It is characterized by early changes in behavior, personality, emotion, and executive function, although subtle episodic memory and visual spatial skills and deterioration have been reported recently as one of the early presentation of a behavioral variant of frontotemporal degeneration. We know today there are several different proteins involved in accumulation of the neurons, which can be reason for a frontotemporal degeneration and behavioral variant. And because of a lack of specific biomarkers for diagnosis of frontotemporal dementia, we basically using consensus criteria published in 2011, which are showed here, and we are recognizing by this consensus criteria 3 different a level of diagnosis, which is a possible behavioral variant frontotemporal degeneration, probable, and definite. Possible, in fact, are a group of several symptoms, and for diagnosis of possible frontotemporal dementia, we need at least 3 of these symptoms present. However, probable frontotemporal dementia, which will include criteria of possible, plus specific focal atrophy of frontal or temporal lobe. And finally, definite behavioral variant frontotemporal dementia should be considered if we have either possible or probable variant present, plus histopathological changes which are showing accumulation of three various proteins, which one is a tau, another one is TDP43, and the last one can be fused in sarcoma protein as accumulated in neurons. However, because of non-ethic biopsy of the brain during the patient's life, definite behavioral variant should be also diagnosed if we have a specific mutation present in patient's clinical picture, and there are 5 different mutations where C9 and progranulin are probably the most common. The main challenge of revised consensus criteria is basically low specificity, and therefore, particularly in early stage of disease, it's very difficult to make a proper diagnosis. And very often we can probably these patients characterized as a primary psychiatric disorder or frontal variant of Alzheimer's disease, which should be excluded in clinical trials. And also other type of dementia are also important for differential diagnosis. Here you can see distribution of various symptoms, progression of disease between frontotemporal degeneration and also frontal variant of Alzheimer's disease. So at the beginning, it is really difficult to make a difference between these two conditions on the basis of clinical presentation. So therefore, one of the options which can be used in clinical trials is basically to make a specific, to assess specific biomarkers, fluid biomarkers for Alzheimer's disease, and basically exclude patients with a positive Alzheimer's disease biomarkers in clinical trials with frontotemporal dementia. Recently, Adam Boxer and his group recommended clinical stages of frontotemporal dementia as one of the help in selection of patients for clinical trial. And there are 4 different stages which are classified as a preclinical, prodromal, early dementia, and mild to moderate disease. And these staging are based on clinical dementia rating scale, which is adapted for frontotemporal lobar degeneration, where basically the global level of the CDR should be 0 in case of preclinical patients, 0.5 in case of prodromal patients, and early dementia with the score CDR1 and mild to moderate CDR score 2. This analogy is coming from Alzheimer's disease staging as well, and I think this is very valuable here, particularly for clinical trials. And you can see what will be definition for each of these conditions. So practically prodromal FTD should be mild cognitive or mild behavior impairment with no functional impairment, whereas phase 3 will be clinically impairment with mild functional impairment as well. Possible endpoints for each of these staging are also provided, where in a preclinical stage, there are biomarkers, fluid neurophysiology or neuroimaging, whereas in a stage 2 will be clinical biomarkers. And finally, in a stage 3, we basically are considering assessment with scales for a clinical and functional assessment and also patient-reported outcomes. It's important to point out here that behavioral variant of frontotemporal degeneration can be easily replaced, particularly at the beginning, with so-called phenocopy of behavioral variant, which is in fact conditioned with different progression and different type of the pathology in early stage of disease. These patients definitely should be excluded from clinical trials because deterioration of their behavioral and cognitive impairment is very, very slow. And you can see here examples in a cohort of 43 patients with the behavioral variant and the phenocopy variant, where you can see quite different slope of deterioration in cognitive and behavioral tools, and these patients are basically representing about 15 to 20% of all patients with the clinical presentation of behavioral variant of frontotemporal dementia in early stage. It's important to point out that these patients have usually no typical changes on brain MRI, like focal atrophy, and they are basically meeting criteria for a diagnosis of possible behavioral variant of frontotemporal dementia. According to this report published 2 years ago by Devaney, it is clear that there is no decline either in behavioral variant or cognitive impairment within the first 3 years of observation in this patients group. Now, I like to point out the review of the randomized placebo-controlled clinical trials in behavioral variant of frontotemporal dementia. And these are studies done and published between 2004 and 2013. And altogether, there are not more than 15 clinical trials of double-blind placebo-controlled type in the patients with behavioral variant in frontotemporal dementia. At the next slide, there are more recently published also results. So you can see, in fact, that total number of 15 studies were published so far, mainly proof of concept studies or biomarker related studies. So practically confirmatory trials are very, very rare, practically the only one, which is HMT, which included 220 patients randomized. It's important to point out that practically 8 studies were in crossover design, 7 studies were parallel, and the mean duration of drug exposure in all of these clinical trials were only 9 weeks, but only few studies had a duration of 52 weeks, which we guess it's a minimum time needed to see disease modification effect in the clinical trials of neurodegenerative disorders. So total number of patients included in these 15 trials was less than 700, and the mean participants' age from all of the studies ranged from 55 to 66 years. Sample size was also humble as well, between 8 and 22, with a median of 36. All studies have used specific diagnostic criteria adapted to the time of the presentation, but the last 7 studies that you can see in this slide use criteria that we already described and were published in 2011. The most common behavior assessment was NPI used, and we've seen huge variation and heterogeneity in the assessment of the frontal and cognitive function. Worldwide clinical trials provided full service in several of these studies, practically the last few, and we basically taken important lessons from next clinical trials for the planning of the next clinical trials, which will be summarized in our conclusion slide here. So from the published papers and also from our own experience, we have some suggestions related to inclusion of patients for behavioral variant clinical trials drug development. Age limit should be between 40 and 70. Diagnosis should be either probable or definite. It's important to avoid patients with a possible diagnosis because of the potential inclusion of a phenocopy of behavioral variant, and also possible diagnosis can be easily applied for psychiatric and also other disorders. It's important to use some of the measurement for the brain atrophy, which we've done in one of our studies. We are suggesting KIPS imaging criteria cutoff 2 or higher to be present at the screening. Stage of disease, according to Boxer, should be also implemented, or level of impairment, including behavioral level of impairment or cognitive impairment. We are also suggesting to include fluid biomarkers specific for Alzheimer's disease to exclude potential patients from the group of frontal variant of Alzheimer's disease. Unfortunately, there are no fluid biomarkers specific for FTD, and therefore, at the moment, we cannot recommend any specific. Exclusion will be patients with phenocopy of FTD, frontal variant of Alzheimer's disease, which is including amyloid positive biomarkers. And also, because of these patients are suffering from many symptoms, we are suggesting to rationalize co-medication. Assessment tools will be differently organized according to symptomatic or disease-modifying effect of the drugs. And these are also including assessment of biomarkers, functional assessments, and quality of life. Finally, what is the role of CRO, worldwide clinical trials, in management of behavioral variant of frontotemporal disease? Basically, we are a company who are very much interested to meet primary endpoints in timelines given. So therefore, we are actively in protocol development, site selection, eligibility review of the patients, rated training and surveillance, and finally, day-to-day study management. As Adam Boxer said, clinical trials in behavioral variant of frontotemporal dementia are still in its infancy, but there is a good opportunity to go with the new biomarkers and new clinical outcome for the further clinical trials. I would like to stop here and thank you for all of your attention.
If you enjoyed this presentation, please let us know. And if you'd like to learn more about how Worldwide can support your CNS trial, please contact us at worldwide.com.